Good afternoon, and welcome to Enterprise Imaging Update, a nice webinar, a new webinar produced by HealthSystemCIO.com and sponsored by Hyland. Just a little housekeeping before we get started. My name is Anthony Guerra. I am the moderator of your event today, and I'm the editor-in-chief of Health Systems CIO. Just a couple of features that we're going to be having during our event today. We have our agree or over-the-top audience polling, which we'll look for you to participate in, and we encourage you to send in your questions or comments at any time using the Q&A panel. Leave the default set to all panelists. And you could download the deck by using the URL on your screen, and it's being sent out in the chat box. Just an idea how we're going to spend our time today. First, we're going to go about 35 to 40 minutes with our main panel discussion featuring Joseph Marion, Principal with Healthcare Integration Strategies, Dr. Cheryl Peter-Silge, Founder and CEO at Vidagos Advisors, and Chris Magyar, Senior Manager of Product Management with Hyland. So without further delay, we're going to jump right in. We got a lot of ground to cover, and we're going to jump right in. So Joe, can we start with you? Can you give us an overview of your organization and your role?
Sure. I started Healthcare Integration Strategies about 25 years ago. I'm principal of that organization, involved with PACS and enterprise imaging for probably the last 23 plus years. Prior to that, I spent a career with a large imaging organization and was largely responsible for bringing PACS and enterprise emphasis to that organization. And primary focus these days is on enterprise imaging and educational aspect of that, in the sense of making sure everyone understands the importance and the value and how it plays in the organization.
Very good, Joe. Thanks for joining. Cheryl?
Good morning. So I have a dual career path. I am a musculoskeletal radiologist by training, and I continue to practice through telehealth, teleradiology commitment to a couple of providing organizations. And then I am pursuing my passion for enterprise imaging through Vidagos Advisors. And I started that firm after leaving the Cleveland Clinic, because I wanted to bring the experience and expertise gained in my experiences at the Cleveland Clinic to other healthcare systems, to industry in terms of developing the appropriate tools that are needed, and to help educate the government about enterprise imaging. When I was at the Cleveland Clinic, I was the medical director of integrated content, which included the unsexy content management solution, but also the enterprise imaging solution, which we integrated across the entire organization from Canada to Florida, and which is now being integrated into the New London facility.
Very good. Thank you, Cheryl. Chris?
Hi, Chris Magyar here. I've been involved in enterprise imaging for a good 20 years now, working for a number of different vendors, doing everything from bringing some of the first intraventricular archives to market to developing some of the early enterprise imaging solutions. My role in Hyland is focused on product management for our enterprise imaging portfolio of products and solutions, which complement Hyland's on-base content services solution or document management solution, and a variety of other content services components. I'm pretty happy to be here today to talk to you all about all of this, and hope I can share some of my expertise.
Very good. Thank you, Chris. All right. Next question. Cheryl, let's start with you, and we got a few things here to unpack, as it were. What are the major non-radiologic specialties creating images in hospitals? What is currently being done with them? And what are the difficulties of not managing them with an enterprise approach? So wherever you want to jump in there.
Okay, so let's start out with first cardiology. And I think we should be using radiology and cardiology almost interchangeable in terms of their maturity as image-generating specialties with fairly well-defined workflows and archiving strategies. So that, cardiology is the next most prolific. What was really surprising to me, and just probably because of the specialty I was in, is ophthalmology. Ophthalmology is incredibly dependent on imaging, optical coherence tomography, and retinal examinations. They generate a lot of images. Women's health, point of care, or not point of care, but just ultrasound is well integrated into most of the obstetrical programs. And from there we go on to the scattering of point-of-care ultrasound systems that are found in every corner of every hospital and every clinic. And then with smartphones, I think we're going to see photographs rival radiology in terms of the actual number of studies that are generated. So when you look at it, especially with photographs, almost every every medical specialty creates some form of image. And we haven't even begun to tap into video. That's going to bring a whole new set of challenges to enterprise imaging. Some of the difficulties when you don't have an enterprise approach. We found that some patients were actually sharing videos with their physicians through YouTube. So, when you don't have a good workflow, nature abhors a vacuum, and people are really creative, and they will find a way to share the information they want to share. But we don't then archive that information and make it available through proper indexing to all the other clinicians that are taking care of that patient. And I can give a personal example of what happens when you don't use an enterprise approach, and that is I'm covering an emergency department, and I have a pelvic ultrasound, and a patient has an abnormality, and I have no other studies on that patient, but the patient told my technologist that they had an ultrasound up in their doctor's office a couple weeks ago. Without access to that information, I can't render as definitive an opinion on the study as I could if I had access to that prior study. So there's an immediate impact on patient care. So I could go on all day, but I will stop at this point.
Well, I have a question about that, Cheryl, before you go on.
Yep.
Would you
Sure.
agree with that a lot of physicians are sort of in a damned if you do, damned if you don't model in terms of capturing imaging? So in the absence of a appropriate enterprise imaging infrastructure, if that physician needs to capture images to share them with other specialists or colleagues, and they lack that infrastructure, they may have to use technologies that violate PHI requirements. Conversely, if they don't capture those images and share them, they may be putting the patients themselves or the organization at risk. So are we really trapping physicians in sort of a damned if you do, damned if you don't model today?
I think today, absolutely. I think that's a really good assessment of what's currently going on today, and I think that we have to recognize that challenge for our clinicians and actually the risk to our organizations with that type of workflow, and acknowledging both of those come in with an appropriate, efficient, easy-to-use solution for them to be able to accomplish the task at hand.
Very good. Very good. Joe, thoughts?
Sure. There are a couple things I'd like to jump in with. One is I think that one of the crucial aspects is the ability to identify images. So I can relate to an experience I had with a rather large West Coast healthcare system that was wrestling with the question of how to do enterprise imaging. And I know this is jumping ahead in terms of some of your questions, but their point was, well, we'll just use radiology's packs. And one of the first questions I asked of them was, how did they intend to identify the patient's, the images to the patient? And I got sort of this deer in the headlights stare as to what did I mean by that. And when you relate in the context of the notion of a radiology order, and that's the mechanism for identifying how you perform the study, I think that was a revelation to them in the context that in many areas that do produce images, I mean, even take the case of, say, dermatology or wound care or something where perhaps maybe they're even being captured on a smartphone. The question is, how do you relate those to the patient? And I think that begs the question in the context of the importance of tying it into the electronic health record such that you can associate whatever captured images you have with the patient.
I think a key point you're breaking out there is you get outside of radiology, in the absence of an ordering system or an order-based workflow, in the absence of a RIS, in the absence of a traditional DICOM modality that supports things like modality worklist and DICOM store. You mentioned reusing the packs, so we'll assume you have some type of storage and view system. What does it mean to implement enterprise imaging in various departments or specialties that lack these things that are just assumed in radiology today?
Right.
And
Go ahead, Cheryl.
I was going to say the other challenge is, and we're getting to that conversation, is metadata. And, you know, most physicians, if you mention metadata, have absolutely no clue what we're really talking about. And secondly, we, being the industry, haven't really set our clinicians up for success by adopting universal standards. Even radiology hasn't been able to adopt universal, we'll call it image labeling or procedure identification standard. And that is a huge challenge that every organization is going to have to tackle for themselves at the moment, while we in the industry try and drive to some agreed upon standard. Many standards exist, but we have to pick one.
Yeah, it reminded me of a story. I was working with a large customer I won't name that had invested quite a bit of energy in capturing a wide variety of medical images and putting them all into a shared repository. And they did an okay job of identifying the images with the patient it's associated with, but had captured almost no meaningful metadata about those images. And I think the challenge after some discussion became clear is that when you go retrieve all of the images for a patient, and it's many different types of images without any useful way to characterize it other than date and patient ID, how does a physician or clinician make sense of, you know, a bin of images? You're almost like you're scrolling through the random images on your iPhone, hoping to find what you want.
Right, and I think the other following aspect of that is obvious in the sense of who needs access to those images, and that relates to the question of workflow in the context of how do you orchestrate the presentation of those images to the appropriate audiences. So it's more than just the storage of images, it's also the accessibility and the viewability of those images.
Yeah, on the bright side, I mean, things have evolved a bit on that space, right? There is more adoption of vendor-neutral archives, so you've got the potential for images from multiple specialties to be stored in a common repository. I think we've largely evolved from the web viewer associated with the radiology PACS model, where you go in your EMR, you launch a particular web viewer for a particular PACS and you see just the images in that PACS. We're in the era of the universal viewer. So from your EMR, you can generally, if you're invested in a space, go to a result, find the associated images, click on them, see a view of all of the images from all of the specialties for that patient over time. So being able to see that and have that organized in some useful way is a reality today that was not a reality yesterday, right? It was exceptional yesterday. Today, it's a reality if you invest in technologies like vendor-neutral archives, enterprise viewers, and integrating those effectively with your EHR.
And I think that's a really key point, Chris, the effective integration with the EHR. People are storing things, say, in tax systems. Where we've got our ophthalmology images, we've got our photo images in there. So they've achieved the archiving layer. They may or may not have identified some form of indexing that is useful. So it's not just wound photo, it's wound heel photo. Ideally, it would be wound left heel photo, so that people don't have to open the images and know what they are. So you address that. And then I think the third is really creating that list and treating all images the same. So just like you open up your lab results tab, you've got every single lab result in there, or you open up your medication tab or your orders tab. And we really need to get people to appreciate that if we feel consolidating all of that information in that way is useful, why would you not want the exact same thing for your images?
Yeah,
and you can't do that without the appropriate, you have to have the appropriate workflow in your EMR to identify those images, create some form of unsolicited order and the encounters-based workflow to have that presentation in the EMR.
Yes, I think it's interesting to note that today it's possible not only to have access to the discrete data in your EHR and your medical images, leveraging the power of universal viewers and vendor-neutral archives, but you can also see into all kinds of documents about the patient, progress notes, PDF reports, any scanned paper. So providing essentially access to all of the unstructured content, whether it's medical imaging studies or not, to that clinician is very much a possibility today. Well, I don't think that was quite difficult not so many years ago.
Right.
All right. Well, that was fun. Joe, are you good? Anything else?
Yeah, Anthony, I guess I would pose this to Cheryl in the context of her radiology experience, in the context of that I think that the emerging area is going to be in the context of the patient. So, in the past, patients have sort of been ambivalent to images, but I think that that's changing, and it's going to present the greatest challenge to healthcare organizations. I know in my own personal health experiences, I'm the the difficult patient who always asks for the CT or the CD of the exam, and I think that that's changing, and that the security aspects of that are tremendous in the context of maintaining that within the organization. I think that the other aspect of that is how you deliver those images to the patient, and again, protecting security of information. So the new technologies in the context of streaming technology that would allow images to be viewed, but not necessarily transferring the full data set to those patients. So I'm just curious as to, from your experience, are you seeing more demand for image accessibility by patients?
Absolutely, and there's actually a surprising body of literature out there that has looked at patients' experience and response to their photos, and it's all incredibly positive, that it actually helps with patient engagement, whether it's a photo or whether it's just their lung nodule. Patients, it takes them up the level on the engagement with their disease process. And so there's a couple of offshoots to that we've already talked about. One is the whole point, making sure images are available at the point of care so that when your clinician is having that conversation with their patient, they just turn the screen. It's no longer a barrier between the doctor and the patient, but actually now the computer becomes a tool to enhance the conversation between the patient and the provider. But patients also overwhelmingly will look at their images when they're available to them. And there's actually literature that shows patients will share those images. Like in one study, over 80% of patients share their images. And in one research, for a talk I was doing, I was finding patients' images on Pinterest. So patients are really engaged with their images, and for us to think that they're not and that they don't want to look at the images, they get scared, it's just the report, it is really not the way to be looking at it. And, just like clinicians, they want access to those things on their phone. And there are a lot of different mechanisms to provide them those images on their phone, most elegantly by integrating your universal viewer with the patient portal of your EMR. That keeps the patient in one workflow, just like we're trying to keep the provider in one workflow. Some of the image exchange vendors offer that functionality. So I think there are a lot of ways to deliver that. But the next wave that we need to get ready for is to allow the patient to direct their images. So Mrs. Smith has her screening mammography done at a small hospital and now is referred to a academic medical center for treatment of their aggressive breast cancer. As part of the process, the academic center would say, get your images. Ideally, the patient could log onto their EMR portal and through that just digitally send their images off to the center that they're going to visit. We haven't really begun to explore all the ramifications of that workflow, and all of those things are going to be good. Good for patient care, good for the academic center to have those images, to have them electronically, to remove a CD. So we have to remember that the patients are 100% at the center of what we're doing, and that's totally true for imaging.
All right,
we're
very good. Go ahead, Chris.
Comment on that. Yeah, we're definitely seeing a lot more interest in the integration of enterprise viewers, universal viewers, with the feature sets appropriately reduced for patient consumption, so not be overwhelming with the patient portals. And then that kind of sets up for additional things, because what can the patient do with it other than view it on their laptop, on their tablet, on their phone? Can they, let's say they're on their PC, can they download an electronic copy and store it? Could they burn their own CD if they were so inclined? Could they share a link to that image to allow their provider or their friend or family member to have the same experience that they're having? The one that gets particularly interesting and sticky is what happens when patients start wanting to send in their own images, that maybe images or videos that were not captured in any particular structured way. And I think we really haven't come to terms with what that means from a variety of perspectives, although I am aware of a couple of situations where it's being done and well-structured can be very effective. But it can also open up a lot of uncertainties and liabilities and challenges.
All right, we have a number of audience questions, so let's take a look at those. First one is, would you consider this encounters-based imaging versus orders-based imaging? I'm not sure what this is referring to, maybe the general conversation, but Cheryl, can you take a stab at that? Encounters-based imaging versus orders-based imaging?
Well, I think you're going to find both exist in your enterprise. Radiology and cardiology are traditionally orders-based. You could try and force orders-based workflow on some of the point-of-care departments, but that's going to be a challenge. So encounters-based imaging to me, is a must component of enterprise imaging strategy to keep our clinicians' workflow efficient and to keep them engaged with the enterprise imaging process. It could be referring to when I said something about images going into the PACS and not having some form of, unsolicited order, and that would be the encounters-based imaging would, in the end run, generally create an unsolicited order or result in your EMR, and that's what generates the identity of that image study on your imaging tab.
All right, very good. Next audience question. I'm going to go to Joe on this one. How do you envision keeping non-radiology images separate from the reading workflow? Radiologists are very PACS-centric, and most do not want to see images from outside the departments, To complicate matters, if the images, quote-unquote, exist and the radiologist made a diagnosis and does not view them, are they liable for malpractice if their diagnosis is incorrect?
Wow, that's a loaded question. I think that the distinction is it all boils down to workflow. So integral to the notion of implementing an enterprise solution has to be to understand the individual service lines' workflow requirements. So just because you push images into an enterprise image management solution does not mean that those images directly pop up to the radiologist as they're reading. So I think that part of that has to do with the emerging notion of workflow orchestration, such that if there are potentially images that are of interest to the radiologist during their read, that those images would be presented to them or be accessible. So the classic kinds of examples might be the radiologist is looking at some chest imaging, but it also turns out that the patient had some cardiac procedures 3 weeks ago. It would be essential that that information be accessible to the radiologist at the time that they are reading.
Very good.
I think there's a bigger problem when you push those images into a PACS directly, that some of the PACS products, anything that gets pushed into them automatically shows on the work list that PACS is offering. Some PACS products allow you to send on back channels that don't show up on the work list using a variety of techniques. And then you've got, risk-driven workflows, workflow orchestration solutions that aren't going to put something on the work list unless the workflow specifically drives it. So I think it's a solvable problem. You just need to be a little cautious about not pushing everything willy-nilly into your PACS and assuming that only radiology studies are going to show up on the work list.
And I'm going to be a little provocative in my comments here. I'm not going to go out on a limb and say it's malpractice, but in the world according to Cheryl, it is our responsibility as radiologists to be synthesizers of information. And if I just talked about this the other day, if we as radiologists believe our role is to interpret the images in front of us, we will become extinct. Our role is really to use our knowledge about images, which should be the best knowledge about the images, and combine it with the other information that exists about the patient to create the best diagnosis. So I won't say malpractice, but I would say it's a not optimal job if you didn't review the other information that's available about the patient.
Suboptimal job. We'll go with that, right?
Yes.
Okay, very good. All right, next question. How do we leverage as an organization EHR vendors to make use of enterprise imaging in the longitudinal care of the patient using AI to drive targeted care for their disease? Do we see this as the next step? Chris?
Well, that's a mouthful.
Yep.
It's kind of interesting as we look at AI and machine learning in this thing, and I've spent some time in some sessions watching the analysis of these different products, and a couple of things seem to come clear to me. One is when used in complementing, and particularly radiologists, the speed to read is improved. The quality of interpretation is improved, particularly for people who aren't specialists in the area, and recognition of less commonly seen or rare things is picked up a lot better than humans who deal better with regular viewing of these things. The challenge, in my opinion, is going to be as these algorithms proliferate and we go from dozens to hundreds of thousands of algorithms, many of which at this point has not received any type of FDA clearance, how do we integrate them into the workflows? Whether that's into the EHR or your enterprise imaging systems, so that we're identifying, okay, this image needs to be sent to the following different algorithms, and these are the type of results we want to get back from them. Here's how we're going to make all of that information available to the radiologist, so it's all completed and ready to go at the time of reading. And you can sort of see what the workflows of that would look like. When you start getting into the EHR and saying, how do I leverage non-imaging machine learning things that are analyzing the discrete data in the EHR, I think that's going to get a lot more complicated. The EHR vendors are going to have to lead the model for how we map their data to the algorithms that are currently available, making sure that we get the results back and available for review. It's kind of a complicated one. Cheryl, Joe, any comments on this?
Well, I was going to ask you, you know, Hyland had the sort of Venn diagram in the past of the EMR, document management, image management. Do you see that AI might become the fourth circle in that diagram, that it's going to be that type of component? I don't know. I think it complements all the aspects of it in its own way. It almost underlies all of them. The question in my mind is, what does the integration look like between, say, the doc management system and AI? What does it look like between enterprise imaging and AI? What does it look like between the EHR and AI? Each kind of has its own distinct thing. So as opposed to being a fourth bubble, I'm sort of seeing as a layer underneath all of the bubbles. Okay.
I think, Cheryl, you mentioned something that is a hot button for me, and that is when you were describing looking at the various tabs within an EHR. And I think that the challenge that the industry faces is the overlap or the integration or, potentially new ways of looking at information in the context of the way that diagnosticians and physicians deal with information. So the notion of I have to go look at the cardiology tab, I got to look at the medications tab, I got to look at the whatever tab may make sense from an EHR glass house perspective, but it doesn't make sense from a clinical perspective, in the sense that clinicians tend to treat instances. So it would be more appropriate to consolidate or present information intelligently relative to what the current issue or problem is relative to that patient. And
I agree with that.
That's the challenge between
100%. You
right.
got it.
And that to me is the challenge between, I call that part of workflow orchestration, but it's the challenge between the imaging environment and all the document environment and the archive, et cetera, is how do you orchestrate all of those together to present information the way clinicians want to see it?
Absolutely. I mean, I've always said it would be kind of cool if you had like Vesuvius Man and you had on his hand and you could, hit on the hand and all the imaging and any physical exam, anything related to the hand showed up. Or if you could take, and I think part of the problem list was in some ways is trying to get to exactly that we don't think about orders and medicine and lab and all of this. We think about this patient has lupus or this patient has psoriatic arthritis, and how do we group the information the way clinicians think rather than we'll call it bimodality with the way the EHR does it. I think that is one of the next biggest challenges for us because the data is overwhelming and you can't just sort through every single progress note.
Exactly.
All right, very good. Next audience question. Chris, let's start with you on this one. It is surprising how immature the image sharing platforms are via PACS or EHR. The small boutique vendors are addressing it, but the major PACS vendors appear to be stalled or not addressing it. Do you see a shift?
Image sharing is kind of an interesting subject because there's a lot of different ways that people go about it. I think a lot of the dedicated image sharing vendors are struggling a bit in their space. Their market segments aren't growing as they expected. There's many different entities competing for attention. Healthcare institutions are being asked to integrate with many different image sharing solutions in parallel. It's sort of a mess. And then we get into ideas like, XDS cross-enterprise document sharing, which is unfortunately not well adopted in the U.S. for sharing that data, where affiliated entities can fairly efficiently query, retrieve their image sharing capabilities. I think what we're also seeing is the expectation that, image sharing is just kind of part of the overall platform, but there hasn't been a lot of standardization in exactly what that methodology should be for doing it. We've engaged in quite a bit of sort of atypical mechanisms for doing things like that, image link sharing, sending somebody a link so they can view an image on the screen, or you can collaborate with your viewing approach. It's kind of a non-traditional thing where you're not sending the study by value in its quantity, but you're sending a reference to the study that can be viewed with rich tools. If you want to download a copy or store it to your PACS, you could, but you just have a secure link to it that gives you that access. So, I don't know, you have to kind of think about what you mean by image sharing at this point. And then you get back to the other aspect, which is really the patient-centric thing of this thing. How does the patient get efficient access and manage their own studies and share them with providers? I mean, I know I find this maddening, right? Probably like all of us, we've all had our fair share of medical imaging studies, and how many of us actually have ready access to all the medical imaging studies from all the facilities that you've had procedures at over the course of your life. I'm embarrassed to say that my collection of them is a mess, and I'd very much like it to be something better and to be able to say, hey, I go to a new provider. How do I bring the whole set of my images from many different sources and states to that provider? And I don't think anybody's answered that really effectively yet.
Very good. Very good. All right. Let's get to our next question. Joe, we'll go with you. Is there a paradigm shift with radiologists and their engagement in the longitudinal care of patients rather than transactional encounters? Many old school radiologists are deliberate about avoiding EI. I don't know if that means AI or EI. How do we get adoption with this group?
Well, I think like everything else that's transpired within radiology, 20 years ago, trying to convince people that speech recognition was an answer to dictation was an uphill battle, and today try to find a department that isn't using that technology. So I think it's an evolution or a process in the sense of demonstrating the value to the radiologist in the context of these different technologies. So, longitudinal versus transactional, I think it boils down to how the radiologist perhaps is most comfortable with making their interpretation, and how one can demonstrate to them how that can be improved. Again, just to use another example from my experience, there was a group in northern Michigan where they were implementing a PACS, and one particular group that was involved in imaging, primarily in chest imaging, they did not want to see electronic images. They wanted to continue to see film because they thought there was more information in the film. And it was interesting how IT and radiology spent a lot of time with this particular group, the thoracic surgeons, in the context of educating them where there was actually more capability and more information in electronic images than there might have been on the film. And the end result was that they became one of the strongest proponents of moving in that direction. So I think, again, it's education, it's persistence on the part of IT and the other organizations that need to present to radiology why there's value add to doing it perhaps longitudinally as opposed to transactionally.
Cheryl, any thoughts about that? They're asking about old school radiologists. Are you one of those?
I don't think so. Although when I used to get my new guys right out of residency, I'd always realize how bad some of my habits were. But I think radiology just as a specialty is really undergoing another wave of transformation. And Joe brought up the introduction of the PACS. And that was a challenge, and dictation systems. Both of those were challenges for our clinicians, but also for our radiologists. A lot of them didn't want to move to PACS. A lot of them didn't want to move to voice recognition. And I think this is just a continued part of our evolution. And part of that evolution, as I alluded to earlier, is going to be what's the changing role of the radiologist as AI may start to replace some of our more repetitive, potentially mundane tasks. In some ways, it will actually free us up to spend more time on some of those complex issues. And when we have the time to do that, I think a lot of people become re-energized about why they went into medicine and what they're doing in radiology. So, I think it will all be a process, and different people will be on different parts of that adoption curve.
Very good. Chris, question for you. Is there real value in archiving all POC images? When does this become noise in the image management system?
I'm not sure I would claim, the only thing I would think perhaps would be noise is the POC images that are being captured for documentation purposes. Tech line placement, guided needle stuff, things that are being really generated, captured, and stored as documentation to justify the billing process. I will certainly defer to Cheryl on this, but I'd be a little hesitant to claim that non-documentation for billing purposes type images are just noise. I think probably a little more careful consideration would need to be made about the types of procedures and the specialty and what the longer-term value of it would be. Now, if it's the case that it doesn't have longer-term value, I think the better question is, are you capturing enough metadata about those images to appropriately manage them over time, to curate them, to dispose of them, to compress them, to move them to lower-cost storage? However you might be managing them effectively, have you captured enough data, metadata about them up front to be able to make more intelligent decisions on how to handle them on the back end? Cheryl, I'll defer to you on the noise question.
Yeah. So I think you hit it on the head with the procedure and the images that are being acquired just to support billing. And, there's strategies to hide those, in the EMR. There are ways to make sure that those exist, but they don't, we'll call it, clutter up the imaging tab. I agree with you 100%. There are a few instances where maybe you would use ultrasound and not want to document exactly what you used it for. So I know one of the OB machines in one of our hospitals, they weren't going to connect it to the system because they solely used it for the purpose of fetal lie. Was it breech or was it not breech? And they determined that, you didn't need to document that. That was their philosophy. And I think what this does is it takes us up to a higher level of conversation. And I think photographs are even more of a potential problem here. As one leader said to me, if you looked at your kids' phones, do you see how many photographs are there? Do you want that in the EMR? And this takes us to governance. So I think the organization needs to decide what they think needs to be documented and what should not be stored long term. And, the legal community, there's no strong answer one way or the other. It's going to be all a philosophical discussion at your organization on save everything, only save very small pieces of information, and then truly defining use cases. And I think this becomes really critical in the photographed world. If you're going to take photographs of a trauma, we'll say, why are you taking each one of those images? Because it's cool? Well, that's not appropriate. Because you're a research institution, okay, or because you're using it to document the clinical state because there's going to be some complications. And if that's why you're doing it, then you need to have standards for how you take those images. So I think we have a lot of work to do with our point of care work in terms of what we should be acquiring and what we should be saving, mainly going back to why are you taking that image? What's the goal of it?
I think there's some good questions. So you look at your enterprise imaging system for this and you say, am I capturing the metadata so I can intelligently manage it? Can I partition it so only the appropriate audiences see it and it's not cluttering up the data for other people? Do I have enough metadata so I can manage it effectively over the long term in there? And if you start running these use cases through and testing your enterprise imaging system and say, how well does it handle these edge cases and these different scenarios? It's a very interesting set of questions.
And I'd love to hear Joe's experience about this with some of the organizations he's worked with about point of care ultrasound and photography and trying to prevent the noise. I think there can be a lot of noise if these things are used incorrectly.
Absolutely, and I think that, again, the notion of who are the players that are involved and what's the type of organization. So I can relate from my experience, one academic center that the legal department came down and basically said you have to keep everything, and therefore, the role of the enterprise archive became substantially greater just based on the legal perspective that information was valuable from an academic perspective. Now, obviously, if ultrasound is or point of care is being used just in the context of, say, positional aspects or whatever, or survey aspects, maybe those images don't have to be kept, but I think that one needs to err on the high side and decide later in those types of instances. The other aspect, I think, is the whole question of compressibility, so that relate another experience on the East Coast where a facility and the IT organization decided that, to save space, we're going to compress everything. And then it was pointed out to them that you can't compress mammography images, or that there are legal consequences of, say, compressing with lossy compression CT or an MRI study, and it was strategically pointed out to them, do you want to encourage the lawsuit where somebody's going to say, could you haven't seen that particular cancer or whatever on this compressed image? And the answer is no. It's not a question of whether, it's a question of how much the lawsuit is going to be. So I think that there has to be sort of a team effort across the organization to logically come up with what makes sense for them in terms of both how much information do you store, how long do you keep it, and in what form do you actually keep it.
Wow, this has been some incredible conversation. I want to sneak in one more. I want to put it to you, Joe, and then we're going to have to let everyone go because we're almost out of time. Certainly think we can revisit this in the near future. Lots of content there. Joe, audience question, how do you propose dealing with bandwidth requirements in imaging? Studies are getting bigger, pathology and video images will be significant. At which point do we reach diminishing return? Do you suggest dedicated networks?
Well, I've run across that numerous times in my experiences. One facility back east, the IT person was attempting to leverage upgrading the network based on the fact that radiology was going to provide all this additional bandwidth on the network. And I think in some instances, the dedicated type network, so say within radiology, being able to move images around without necessarily using up the bandwidth of the hospital network has some definite value from that perspective. I think the other twist to this is the emerging technologies in the context of streaming technology, so that instead of physically moving information from one point to another point and even out to the patient, as I mentioned previously about the security aspect, advantages of that, there's also the whole bandwidth aspect of that is that if I can present simply a web browser view into a data set, I'm not using as much bandwidth to physically move all of that information to another workstation, and perhaps those types of technologies I think are going to be valuable in addressing that concern.
All right. Chris, any final thoughts before we get rolling?
I think Jay's spot on with that. I would probably add the comment that the combination of server-side rendering and streaming mitigates that. The idea of dedicated network infrastructure to solve that problem strikes me as absolutely not the right way to go. Just a quick closing thought. I think the principal challenge that I see is how do we help organizations understand the value proposition that an enterprise imaging strategy brings to them, and the costs and the risks that they are incurring by failing to define an appropriate enterprise imaging strategy, and the governance to go along with it.
Very good. Cheryl, final thought?
Oh, Chris stole my final thoughts. I think that is the biggest challenge that we have going forward. I guess the additional thought that I have that we didn't cover is, well, first of all, I'm so glad so many people were on this webinar today and sent in such great questions, because that tells us we are getting the message out. So first of all, I'd like to thank all the participants. But the next question is, who should be leading this within an enterprise? And how do we continue to educate that target audience? I think in the past, we've been directing a lot of this at the radiologists and a lot of the physicians that are very heavily engaged in technology. And I can tell you, I was so excited to see this invitation come out and that we're directing some of this education towards the CIOs, because I think that they are going to be critical in helping educate and bring these capabilities to their institution.
Thank you. Well, what a tremendous, tremendous panel. Really one of the most enjoyable ones we've done, and certainly the flow of the conversation was great. The audience questions were tremendous, and there's a huge interest in this topic. So thank you. Regarding continuing education, those of you who hold the CHIME CHCIO certification get 1 CEU for attending our events. So let CHIME know you were here, and if you've asked us to do so, we certainly will. If you need a certificate of attendance for another CEU program, you can use the final slide in this deck. You'll receive an email when this recording has been posted to our on-demand channel, so keep an eye out for that. If you'd like to sponsor an upcoming event, one of our booked events, or to book a custom event, you can check out our website or contact Nancy Wilcox from our team. And you can go to our website to register for our upcoming webinars. We have a robust lineup coming up. So with that, I want to thank our featured speakers, Joe Marion, Dr. Cheryl Petersilge, and Chris Magyar. And I want to thank Hyland very much for making this conversation possible, and our audience for attending. So with that, everybody have a wonderful day. Thank you.
Thanks, Anthony. Thanks for